come in front. Anu, come here on the Roxana, yeah, all. And so we go. Now, where is the?
Thank you. Thank you.
Okay, so we had iPad like a disappeared, a spontaneous combustion, unless somebody took it by mistake. I had it here. No, it was here. I was with you.
Do you think maybe
You have to
Dr.
see it there.
Narula mistakenly
Narula
took
or that, I don't know, somebody definitely took it. But anyway, those who are here, now, can you, Kim, can come questions on your phone or something? Yeah, let's see if somebody comes. Yeah, we need to get some questions to all our great faculty. I'm sure they were very clear and explicit in the message, but I'm sure still will be some questions. So now we have the speakers on the side. Okay.
Where's my question slide?
Yes. And you have this, the QR code.
So questions are here, but it might have been from.
Earlier one.
Also, you can ask questions in the audience.
Right. So question can ask from the.
Also, there's mics on the tape on the floor.
Okay.
Oh, you mean that iPad?
Yeah.
Where?
No, your iPad was somewhere. I took it there. But anyway, so no, I took it on my side. It's somewhere. You can find it on the seat. But let's. I'll start it. So I know. Actually, last year we had a very little audience, but the most cited lecture was of Dr. Mehran's on is the time to retire aspirin. There were like more than 5,000 hits for that question. So question comes down. People still, since the news has come into the newspaper and all, people are asking, even you have a diabetic, but you have no CAD, you didn't have any stents or MI. What is the recommendation now? Should they take aspirin? Which group you will say who do not have a documented CAD or PAD and should take aspirin, or nobody should take aspirin?
No, I mean, obviously, certainly the primary prevention trials had really did not show very good evidence, even in the elderly, even in our, maybe in the diabetic patients. So in my mind, I think what I do is I look at the risk factors, and if there's a lot of risk factors and the calcium score is high and there are other important risk factors like Lp(a), which I measure in everybody, and LDL, and obviously statin therapy is so much more important than giving them aspirin, and diet and exercise and a better mental health, less stress, all those things really, really helping. I will give aspirin to those patients who are quite high risk, especially if they have 2 or more risk factors, and especially if the calcium score is high.
Now, Fred, I know you've actually educated us today about his bundle pacing and the left bundle pacing, and so what is your kind of preference at your institution? Which one is more preferred, and what are you doing at present?
So a couple things. First of all, remember, it's pretty straightforward. There's 2 reasons for bradycardia: sinus node dysfunction and AV block. I think in patients with sinus node dysfunction, the progression in most patients to AV block is pretty low. And, left bundle branch pacing is not going to replace sort of a normal native QRS. So, I mean, if it's bradycardia due to sinus node dysfunction, I think it's reasonable to not even fiddle with sort of anything sort of fancy. With AV block, then the decision then is sort of the site of AV block and sort of thinking about that and worrying then about progression. And it's going to be an individual sort of choice, truth be told. So a couple issues here. Really, I think it's important for people to think about device implant over the arc of a patient's sort of lifetime. And I don't think we do that enough. So it's one thing to put in a device, let's say an 80-year-old, and it sounds morbid, but may go through maybe one gen change only, but sort of that's it, as opposed to a younger person. While in a younger person, we would love to do his bundle pacing, there is no question that with the current technology that we have, you have higher thresholds. And there's going to be then higher amounts of generator changes in those patients who need ventricular pacing. So
Do it again. Yeah. The key is that the tier, particularly functional mitral regurg, has shown, it's come into the guidelines now. So any type of subgroup of patient with functional mitral regurg where you'll be cautious or may not be, will not recommend doing the tier procedure. So Roxana, question for you. What about carotid disease? The patient has asymptomatic or just little dizziness. They did a carotid ultrasound, found 25, 30% carotid. Should that patient be on aspirin?
I mean, I think when you find carotid disease, there's probably disease in other places as well, like peripheral vascular disease, which would then, this patient would then be a peripheral vascular disease patient. So whether it's aspirin or clopidogrel, I actually favor clopidogrel in those patients instead of aspirin. But there's no real data on specifically that specific patient. Just like you were saying, that clinical trials just are a sliver of what we see on a daily basis. But putting this together, I think those patients with peripheral vascular disease would do well with a P2Y12 inhibitor.
Okay. All right. Any question from the audience here? Otherwise, we can. Oh, yes.
Are you giving rivaroxaban to people with peripheral vascular disease?
I think in those patients where, I mean, first of all, there was, I didn't get a chance to, I would need like 3 hours to give you a lecture on all of these things. So patients after a peripheral vascular intervention, the Voyager trial showed that rivaroxaban 2.5 milligrams POBID with aspirin was definitely superior to aspirin alone or even clopidogrel and aspirin. And so I think, for sure, those patients would benefit, especially if they're not at a high bleeding risk. So yes, I am doing that, especially if they have high thrombotic risk and multitudes of other things. It's just that it's very, very hard to find that patient population who's not at high bleeding risk, who's got a huge thromboembolic risk, where you believe that these factor Xa inhibitor like rivaroxaban, that's been so well studied in that population, is being used. First of all, and also you need to understand, if you look at our communities in the low socioeconomic, the social determinants of health will tell you that many, many of our African-American patients, Hispanics, and in certain zip codes are receiving amputations rather than evaluation for their peripheral vascular disease and getting the proper guideline-directed therapies, such as the use of these antiplatelet, antithrombotic regimens. So we need to do better than what we're doing. And what we saw in COMPASS was a 70% reduction in limb amputations. This is no brainer. Those patients should be on it.
So I'm sure if the COMPASS investigator do the trial again, they will took the third arm, which was 2.5 plus aspirin. I think going forward, they would have only 2.5 twice a day. Yeah, and no aspirin, and that bleeding issue would have been mitigated completely. So I think that as they did not have the 2.5 milligram twice a day without aspirin arm. I think that's where the concern, everyone, because what we are worried about nowadays, bigger concern is the bleeding. And we have shown that always, determine the long-term outcome. Yes?
Is there any time you recommend aspirin alone as antiplatelet? Any condition?
Of course I do. I don't want to say that I'm not an aspirin hater, but I do believe that there are, I think we need to be thinking for our patients. I think often physicians get too comfortable. They just say, okay, aspirin forever, bye-bye, see you in a year. I don't think it should be that way. We have to be constantly evaluating what's the GI risk, what's the GU risk, what else is going on, and what other medicines are they on? And then, of course, there are a lot of my patients who are on aspirin. I'd rather them be on aspirin than on nothing. And even though clopidogrel is quite quite cheap. It's not, doesn't work on everyone. So you still have to be kind of thinking about that.
I'll just add one thing. I think what you heard from Bism's and Roxana's and my talk is that these disease states are chronic. I mean, we think about, this angioplasty as sort of a battle to be won or lost, or this, CABG or an AFib ablation or whatever the case may be. But someone has AFib, they're going to have AF long-term, and you have to manage all of their issues. Coronary disease, same sort of thing, where it is a lifelong piece. And what Bism mentioned, you have heart failure. That is, even if they have improved LV function, they are in remission, but they haven't been cured.
Yeah, exactly.
Okay, last question from you now.
Sure. I think in Compass, the rivaroxaban with the aspirin starts about a year after the index event, which is an acute MI or an intervention. What happens if you stop the aspirin earlier, and if it's an intermediate, moderate bleeding risk, would you start the Xarelto with maybe aspirin or without earlier than a year? And the second part of the question is, there seems to be an overlap in the indications for the Compass formula and the ticagrelor 60 milligrams twice a day. What's your preference and experience with this?
So those are all really good questions that the Compass trial doesn't answer. And the unfortunate missing link here is that when the company found these results, it was almost like they lost interest in rivaroxaban. And there was never a very good translation of the use of rivaroxaban after PCI, after an acute coronary syndrome. When do you switch over to this Compass strategy? That switch is one that clinicians are most confused about. So you're on aspirin and ticagrelor, or then you go on ticagrelor monotherapy. When do you switch over to Compass? Is it 1 year? Is it 2 years? Is it maybe whatever it is? And the fact that the patients on average got randomized or evaluated about a year after their PCI or STEMI or whatever. But remember, these patients were with chronic coronary disease and peripheral vascular disease. They looked for high-risk chronic patients. Nobody was acutely unstable. So it's really about a chronic maintenance strategy in a certain patient population. So you can imagine that if you have a patient that has a low bleeding risk, who has coronary peripheral vascular disease, diabetes, and a bunch of other risks, but no history of bleeding, you may want to be considering a Compass strategy for that patient, which would include rivaroxaban plus aspirin. Most don't, because it's just there was never this, how do you hand it off? How do you change it over? And you would basically stop the ticagrelor and the aspirin. I mean, you would keep the aspirin, low dose aspirin, and you, instead of ticagrelor, would be giving rivaroxaban. It's hard to do that when your patient is doing extremely well on, let's say, ticagrelor monotherapy, has never had a bleeding event. You know that they're being protected, because Pegasus also showed similarly that there was protection in those same kinds of patients. So how do you choose? It's a difficult question. I don't know how to answer that. So you have to choose one by one. If they have, and then if they have atrial fibrillation, all bets are off, because that Riva dose is not good enough for stroke protection. So you have to then go to an oral anticoagulant monotherapy at that time. So it's all very, very personalized, if you will.
Okay, I think time to wrap up this last but one session. For excellent to all faculty.